I'm very delighted to introduce you Dr. Mira Malcov, which is the head of the Ph.D. laboratory at Tel-Aviv Ichilov Medical Center. And she will talk today about IVF and Ph.D. and genetic testing. Mira, the stage is yours.
Good morning, good evening. First, I want to open with a slide with some very important remarks that remind us that all of us are a carrier of dozens of severe genetic mutation, although most of us are not in a risk for affected offspring. And I will talk on this in the presentation. I want to reflect that and remind that this is our responsibility to make the correct decision to perform genetic screening test and prenatal testing to prevent the birth of affected child, and to create legitimation for the required genetic procedure based on evidence-based knowledge and understanding, and to learn about how prenatal and preimplantation genetic testing are performed and what are the advantage and disadvantage of each approach. Okay, first I want to apologize for my English, which is not my mother tongue, and I hope that the English slides will help you understand if I will make some mistakes. In this talk, I will present a genetic diagnosis of embryo at a very early stage, only 3 days following the fertilization. The method is called Preimplantation Genetic Diagnosis, and it constitutes an alternative to prenatal testing by amniocentesis, for example, for couples that already diagnosed as carrier of severe genetic disorder. And this is why they have a risk of 25 to 50% for an affected offspring. I will focus on the rationale and how the procedure was evolved, on the new approaches, the challenges, the obstacles, and the advantages and disadvantages of this method. First, I will start with a short introduction to human genetics. It is not, I said it very, very briefly, but just to make you familiar with the terms. So as you know, our body evolved through million years of evolution into the superorganism we're familiar with, and it is now composed of highly differentiated and specialized organs and that compose out of tissue and cells. The appropriate structure and function of the lung, liver, heart, and other organs depend on the perfect structure and activity of the protein for which this tissue composed of. But actually, the health and the disease of this wonderful and perfect machine depends on the genetic code, the written in the DNA that is localized. I will try to mark it with, this is the cell, the blue, and in the center of the cell, there is the nucleus that the DNA is lying there, and every cell in our body contains this nucleus and the DNA. The DNA determines the quality and the quantity of the produced protein that will eventually build the body and will be responsible for all the metabolism and structure and enzymatic reaction. According to the well-accepted central dogma, the DNA in our body, in the all nucleus of the cells, is transcribed into messenger RNA. You may be familiar with the name messenger RNA for the corona vaccination. And this messenger RNA is a kind of a copy of the DNA, and it leaves the nucleus into the cytoplasma. And if you can see Here, the small dots, these are the ribosomes that can translate the codes of the messenger RNA into protein. The deviation, this is, wait a minute. This is a sequence of normal gene, and you can see that in this point, the letter T is substituted in the letter C. This tiny, almost unrecognized substitution can be devastating and cause lethal sickness and death, as you can see in many sickness, and also in the GNE that you're familiar with. In this talk, I will concentrate on two muscular dystrophy diseases, the SMA, spinal muscular dystrophy, and the DMD, the Duchenne muscular dystrophy, as example for studying the pathophysiology, the genetic basis of the disease, and compare it to GNE myopathy. I will describe the constant struggling of researchers to reveal a cure and complete healing, parallel to more efficient effort to defeat this severe disorder by screening tests and developing a genetic selection and prevention program like the Ph.D, the Preimplantation Genetic Diagnosis screening. DMD is the most common cause for muscular dystrophy. It affects 1,000 to 3,500 males. The disease results in early muscle degeneration, and until the age of 12 years, the child will need a wheelchair. The death cannot be prevented, and it happens on the third decade. Usually, the mutation is mapped to the largest gene in human, which contain 79 exons. The gene dystrophin is located on the X chromosome. This is why only male are affected. And it encodes a structural protein that connects the fiber of the muscle into cell membrane. This is the dystrophin. When the protein is truncated or absent, the muscle begin to degenerate, and the degeneration of the muscle is in all body muscles. Many efforts were invested in developing a therapeutic treatment, since the disease is characterized with early onset and it is extremely lethal. In addition, until recently, screening tests for carrier diagnosis was not available. The idea was to use a chemical agent that promotes skipping on the mutated deletion exon. I will try to show it. Sorry. For example, here the mutated deleted exon is number 50, and because of this deletion, the protein that is produced is truncated and is unfunctional. But if we will be able to use some chemical agent and to skip this deleted exon, we will get some functional, although the protein will be shorter, it will be still functional dystrophin, and the disease will be very mild instead of the lethal one. Another example is the spinal and muscular atrophy, which is also lethal disease. It caused by recessive mutation because of a deletion of 2 coding units in SMN1 gene. The absence of the SMN1 gene protein results in early progressive weakness and atrophy of body muscles. In several forms of the disease, type 1, for example, the severe one, the child will be die within 3 years from birth. And it is, I saw such babies, and it is really very hard to look at it. And maybe this is why many efforts were done, and we can see very rare example of scientists who could develop a medicine that was able to really cure the disease. Two types of treatment found to be efficient and theoretically turned the SMA lethal disease to a curable one. The first medication, Spinraza, utilized the existence. This is a diagram of part of chromosome 5. You can see in yellow the real gene, the SMN1 gene, which cannot translated into protein when exon 7 and 8 are missing in a sick child. But very close to this gene, there is the SMN2 gene, which is very similar gene, but naturally it cannot be translated into active protein. And what the medicine do, it forces it to express, and because of some expression of this gene, it compromises the lack of the SMN1 gene, and the child can be really function and feel like a healthy one. The problem is the price. This treatment is cost $2.25 million for 5 years of treatment. And of course, many people say that why to put so many millions of dollars when this disease can be prevented by screening test or PGD and PGD. Another medical treatment from the same disease is the Solgen SMA. In this treatment, they inserted the gene, the normal gene, to a virus and inject the virus, the engineering virus, into the sick children, and they could get in a single injection a total cure. The same price, $2.something million, and I think we have to take also the price in our consideration, whether in a limited health budget, it is still justified to do it. In GNE myopathy, as you're more familiar with, there is a well-known characterized mutation, and they also know the pathophysiology of the mutation. They know that because of the mutation in the GNE, there is a lack in celiac acid. And although everything is known, external administration of celiac acid is resulted only in a limited improvement, as you probably know better than I do. Other medication, as far as I read, couldn't demonstrate the desired improvement. So I hope I already convinced you that even when the etiology of the disease is known, usually it is not guaranteed for the development of an efficient medicine finding the cure to the disease. And it seems that whenever it is possible, like in other many situations, preventive medicine is beneficial. When we talk about genetic disorders and we talk about preventive medicine, we mean that we have to perform and put a lot of attention and money to develop a screening test, mapping the population with increased risk, and develop protocol for diagnosis of embryo in risk. Usually, it is beneficial on any medication treatment. This is especially true when, like in the GNE myopathy, when there is only one mutation that is very characterized to a certain population. Here it is the methionine in position 743 that actually very tiny change. It is only one amino acid that was substituted in another, but you can see that the results are very significant. So the reason is that probably that a large population with a random mutation of a single individual became, from many reasons, smaller, and probably marriage within the population turned this mutation to be very common. So first, I want to mention that every one of us, now we know it because many DNA sequences, whole genome sequences are performed, and many people, healthy and sick, know they're all mutation, and we know that each of us, whether he knows it or not, each of us carry hundreds of little mutation, but most of us do not aware of it and are not in a risk for affected offspring because the mutation of one of the partner is located on another gene that the location of the mutation of its partner. To be in risk for affected offspring, we have that both mutation of the mother and the father will be located on the same gene, which is typical to a population that were close and were not involved in other population. But when both partners were diagnosed with a recessive mutation in the same gene and have the risk of 25% for an affected offspring, or if one of them is a carrier of a dominant mutation and the risk for affected offspring is even higher, 50%, then they will have to consider their reproduction options to prevent the birth of an affected offspring. In the past, when the molecular basis of the genetic disease was unknown, such a couple probably would opt in adoption or sperm or oocyte donation. But the years passed, and in 1960, the structure of the DNA was revealed by Watson Crick and the forgettable huge contribution of Rosalind Franklin. You may read it. It is very interesting story, very anti-feministic story. And a lot of effort were dedicated to decipher the secret of life, because just knowing the structure of DNA was not enough. We tried to know the genetic code. Although even before the genetic code was revealed, it was already clear that something in the DNA sequence is responsible for our health and as well as our sickness. And 10 years later, they deciphered the genetic code. They found that every 3 letters out of the 4, A, C, T, and G, every 3 letters serve as a codon for one amino acid. For example, you remember the famous mutation. So if I will find the arrow, here. So you see that that every 3 letters in the DNA serves as a codon to one amino acid. For example, you are interested in the methionine that turned to be threonine. So you can see here, oh, I lost the arrow once. Oh. Here, the AUNT is the same. The ATG is the codon for methionine, and substitution of the T to C, ACG, this is the whole and the only tiny change that caused the disease, the substitution of the T to C, and this is why the codon from methionine became the codon from threonine. Here I see it. Okay, the ATG that called methionine become ACG that encodes threonine, and the substitution of methionine to threonine in the protein makes the whole difference and turn the protein from functional protein to protein that when both copy, the maternal and paternal copies, are both affected with the same mutation, the level of the protein is too low and start to make harm to the muscles of the body. Okay, so now I hope I convince you that whenever the genetic mutation is characterized, I can check, I know exactly what happened, and theoretically, but not only theoretically, it is possible to check it in any sample of DNA that you will give me. For example, if we will return to this couple that are already know that are a carrier of some genetic recessive disorder and have a 25% for an affected offspring, now what should they do? They are pregnant and they are very worried whether they have an affected offspring or healthy one. So usually until 20 years ago, physician tell them, okay, reach to 18-week gestation, and we will sample the amniotic fluid, which contains cells of the embryo, and we will tell you until you reach week 20, 21, we will tell you if the embryo is healthy or affected. So this woman, this couple, went through emotional trauma, especially if the embryo found to be affected, and the woman should underwent really a labor. So in order to decrease this trauma, physicians start to sample earlier at 20 weeks to gestation, and they start to sample the part of the placenta, the chorionic villus, which is the embryo part of the placenta, and the results were received within 2 weeks, and the trauma was much smaller. But if we take this trend and we take it one step further, we can suggest a totally new challenging way. Maybe it will be possible to diagnose the embryo even before the pregnancy has begun. It sounds really like science fiction, but the answer is yes, we can do it, and we can do it in a way that we will ensure the normality of the embryo in advance. But you know that there are no, everything has some cost, and for this project, we need first teamwork between the IVF laboratory, the embryologist that will be able to take the embryo 3 days after the fertilization when it contains only 7 to 9 cells, and take very gently one cell and return the embryo to the incubator. And the PGD lab, the molecular techniques that will be able to develop and calibrate a very sensitive and accurate and reliable diagnosis method that will be able to diagnose single cell and to give within 24 to 48 hours an answer, a diagnosis to the laboratory IVF, and tell them which of the embryo is affected and not suitable for transfer, and which of them is suitable for transfer and will give the pregnancy and the birth of a healthy baby. So the advantage of this approach are very clear, but because there will be no need in pregnancy termination. However, there is also a significant disadvantage because a fertile couple will have to undergo in vitro fertilization treatment that includes daily injection of follicular stimulation hormone. You know that in the ovary, naturally in the ovary of a fertile woman, 1 or 2 follicles that contain oocyte in each follicle is developed each month. But in IVF, and especially in IVF that involve also PGD, when we know that some part of the embryo will not be suitable for transfer because they are affected, we want to have more than 1 or 2 embryos, and this is why the woman will have to to inject something like 12 days of stimulation follicular hormone, and during these days, blood sample will be taken to follow the level of estrogen and progesterone, and the ultrasound will measure. You see here, I cannot see the arrow. Okay, I cannot find the arrow. And you see in the in the left lower part of the slide, those dark circles, these are the follicle in the oocyte that you can see and measure through ultrasound examination. And when the hormone level reach to a certain level and the size of the follicle reach to something like 2 centimeters, then the woman is received another hormone that is ovulation hormone, and the oocytes are aspirated from the ovary under light anesthesia in a surgery room. The oocytes are denuded from the I don't know why I cannot see the circle. Oh. So this is how the oocyte aspirated from the ovary. It is accompanied by cumulus cells, maternal cumulus cells, and is denuded from this cell in order to prevent maternal contamination when the embryo will be tested. And also we want to avoid paternal contamination, so we won't put 2 hundreds of or million of sperm cell over the oocyte, but we will inject a single sperm cells into the oocyte, and this technique called intracytoplasmic sperm injection. So by these two techniques, we avoid maternal and paternal contamination, and I will explain later why it is so important. So as you can see, the fertilized egg, you see these two circles, it's called pronucleus, and in each of them, the paternal or maternal genome is organized, but only for a few hours, because right after this appearance, both pronuclei will join together and will create the first genome of the embryo. Several hours later, the embryo will enter to the first cell division. Here you see the division from one cell of the fertilized egg into two cells of the embryo. And on the third day, 72 hours after the fertilization, we will have embryo with 7 to 9 cells. It is important to say that each of the cells has the same genetic constitution. So if we diagnose one cell, it is the same as we diagnose the whole embryo. And biopsy of the cell in this stage cannot harm the further development of the embryo. And now we can take this embryo, and by laser beam, we can make, you see this, we can make a hole in the envelope of the embryo, and with a fine needle, we enter into the embryo and we take very gently, you see, one of the cells into the pipette and take it off the embryo. Now the embryo is returned into the incubator for another 24 or 48 hours, and the single cell is taken by the Ph.D. lab to diagnosis. So if you see that each of these embryos were sampled, and the single cell, of course, it is not something that we can see in eyes, it is only for illustration now, but the single cell is located into a tiny tube, and then it depends what are the things we want to check. If the mutation, the familial mutation involves some large chromosomal area, we will probably use a chip array or NGS technique if you heard about it. But most of the syndrome, the genetic syndrome, are a point mutation. And for this, you may heard already the name PCR. We will use the polymerase chain reaction. For example, if embryo number 2, 3, and 5 found to be healthy, we will transfer into the uterus and hope that a healthy baby will be resulted. And if other embryo found to be affected, there is an option just to discard it. But in our center, there is a stem cells laboratory, and we usually, if the couple gave their consent, take them into research of the genetic disease. So if I clearly explained, now you will ask me, so what is the big deal? It seems very, very simple. Just take this cell, diagnose, tell the IVF lab which of the embryo is affected and which is healthy, And that's all. So in order to tell you that it is much, much more complicated than what is looks like, I will take you deeper into a procedure and focus on the obstacle, the challenges, and the solution. So there are two major limitations in PGD, which are the time that have for the diagnosis, and the main obstacle is the very, very limited amount of DNA. We will begin with the simpler limitation, the time. We have only 48 hours to provide a clear diagnosis of each of the embryo we sample and give the answer to the IVF unit. This is a definitive time frame that depends on the receptibility of the uterus. And if we will return the embryo out of this time frame, probably no pregnancy will achieve, and the transfer of embryo will be just a waste of not only time, but also a waste of an embryo. Concerning the DNA amount limitation, it is well known that a PCR reaction and other molecular techniques are very simple and accurate when millions of cells are available for diagnosis. However, when only one single cell is served as DNA template, and the cell contains only one maternal copy and one paternal copy, a great effort should be made in order to get a reliable result. This is why we developed a completely new protocol called single-cell multiplex nested PCR. The PCR reaction mimic. I want to know how long do I have it still? Maya?
5 to 10 minutes.
Wow. Okay, I will try. So I think.
If you're available, we can go longer. It's up to you. Don't feel rushed.
Okay. So the PCR reaction is actually mimic the natural process of DNA amplification in cells that takes place prior to cell division. For the PCR reaction, we use a special enzyme that able to polymerize new complementary strand of DNA according to the DNA available template. For the amplification of the single cell, we put the cell in a tiny tube that contain the cell, a special nucleotide, those bases A, C, T, and G, and short DNA fragment called primer. Those primers direct the artificial machinery of the amplification to a specific region of the DNA, because we don't want to amplify all DNA. If we want to diagnose gene E, so we will take primers, one primer in the start position of the gene E gene and the other in the end of the gene, and then we will get the amplification of only this gene and not other part of the DNA. So those two primer beginning and, for example, in the substitute mutation or in the deletion mutation, and in this way we will be able to diagnose all family members from this mutation. So now every cycle that the machine do in the amplification turn one copy to two. So if we have 2 cycles, we will get from 2 copies 4 copies, and if we have 4 cycles, we will get 8 copies, and so on. And after 40 cycles, if we started for one single cell, we can resume this reaction with many thousands of copies of the same gene that we are desire and want to characterize it. And it is not just by a chance, and it is really actual even today, although it happened many years before, and Kerry Mullis won a Nobel Prize, and the committee says his invention is highly original and significant, virtually dividing biology into the two epochs of before PCR and after PCR. And I think every genetic diagnosis or manipulation, and even other examination like the coronavirus, you know, they use PCR and other identification of other microbes. They are all use the PCR reaction, and it really changed not only the genetic field, but also the whole medicine. But when you are doing PCR of a single cell, there are several pitfalls. First of all, because there is only one cell of the embryo within the tube, if my cell or other cells in the lab will accidentally get into the tube, I may give the diagnosis of myself instead of the embryo. And if the embryo is affected, I may think that it is healthy and give an order to transfer it to the uterus. Another problem is that in such a tiny amount of DNA, many times I can have no result at all, what is called amplification failure. And the worst thing is that I can see as if the reaction worked properly, but actually it amplified only one of the allele. And if the embryo is affected and I cannot see the amplification of the affected allele, I once again can make a terrible misdiagnosis and think that an affected embryo is healthy and transferred to the patient. It is very easy to prevent contamination, as I said before, use intracytoplasmic sperm injection, to denude the oocyte, to work in a sterile room and in appropriate clothing, to use bleach for all bench, and to use UV radiation. It is more complicated to increase the sensitivity of the DNA, but as I said, we developed a method to do it. And as you can see, in this is the results of single cell that were isolated for healthy, for a carrier, and for a affected homozygote individual. It is a single cell, and you can see that I easily can differentiate between the normal, which the line is a little bit higher, and the carrier, which has two lanes, and the homozygote, which the line is a little bit lower. So if I am able, and it's just a sample, we can do it for every mutation that is known and characterized. We can design some reaction that will be differ between the normal and mutated allele. But before the couple enter Ph.D. and especially IVF program, I want to validate that I'm sure that I can do it in an accurate and sensitive way. And this is why I'm taking a blood sample from the family member for normal, carrier, and affected, and I isolate a single leukocyte under microscope and put every single cell in a tube. And this tube, these cells will serve as a negative and positive control for the PGD reaction. So this was the situation 20 years ago. And when I established the lab, it was some moment that my boss tell me, okay, we have to start. Everything is ready. And I was afraid. I said, I don't want that a couple will get into this very complicated procedure. And maybe, I don't know, maybe something will happen. And I won't be able to give the desired answer. So we really thought about it, and we said maybe we will start with carrier diagnosed in a screen test, and they don't have some very sad story in their family. So I will be more comfortable with this, or maybe I will start with patients affected with dominant syndrome, so they are affected anyway, or maybe the first couple that will ask for, and there were several couples who want to feel a part of something that looks for them as a science fiction. But then we decided to choose a couple who need IVF anyway. So if we won't succeed to do the PGD, we didn't make any harm. So the first PGD cycle we performed was for the diagnosis of Duchenne muscular dystrophy. We're back in the muscular dystrophy diseases. And the patient found to be a carrier of DMD after her brother was found to be affected. He was very ill at the time of the treatment. Actually, he was dying. And the mother, his mother, and the aunt also diagnosed as a carrier. And what makes this family to the perfect, I'll say it uncomfortably, but the perfect candidate for the first PGD cycle was that her husband was a severe male factor. As I say, for an accurate diagnosis, I had to take a single cell from the affected, very sick brother, and it was really hard to do it physically, and he was very, he suffered a lot, but he said, my last wish is a healthy child to my sister. And when all the preliminary examination on single cell give the desired result, she entered the PGD cycle. 3 embryos she produced were suitable for the biopsy, and we took a single cell for each embryo. We diagnosed the single cell for the deletion of exon 46, 47, and because the Duchenne muscular dystrophy is in male only, we also analyzed the gene SRY, which exists only in male. And this is the results. In the left side is the control cells, 3 single cell of me. And you can see that there is exon 46, there is exon 47, but no SRY gene because I'm a female. And you can see on the on the adjust part here is the cells that isolated from the affected brother. You can see that there is no exon 46, there is no exon 47, and there is SRY gene. So this is the pattern of cells of affected male. Now we go to the right part of this figure, and you can see that we biopsy from embryo number 1. You see here we biopsy 2 cells. You can see the existence of exon 46, the existence of exon 47, and the existence of SRY gene, which means that this is healthy. It is a male, but a healthy male. Embryo 2 represent the same pattern of the affected brother, no sign of exon 46, no sign of exon 47, and SRY gene. And the embryo, the third embryo, is a healthy female, and it has the same pattern of my single cells. The same we did, I don't want to get into more details, for SMA, exon 8 and exon 7 were diagnosed, and the first 2 PGD babies born following diagnosis of Duchenne muscular dystrophy and SMA were healthy and gave a lot of happiness to their family. You see here, it is really nice to see. This is the Brit Milah of the healthy baby that was born follow PGD. And you can see that his older brother, which is affected in SMA and sitting in a wheelchair, not in a good situation, hold it. And I think this is what is so nice, that you can feel as a laboratory worker, that you can take the knowledge and fix the genes. And I think I will stop here.
Thank you very much. So now it will be a good time for Q&A. If someone wants to ask a question, or if something is misunderstood, or maybe something personal. So this would be a good time. So you can ask a question with open your mic, or you can write them down at the chat.
Thank you, Mira. This was a very fascinating presentation. This is Tara. I'm wondering, are there risks associated with this procedure?
Not bigger risk than in regular IVF. There is a risk for overstimulation of the ovary. There is maybe epigenetic risk. It is more theoretically than empiric. But surprisingly, the biopsy of the embryo and the lack of a single cell probably do nothing to the embryo.
Any other questions?
I have one. I don't know if it's appropriate in this forum, but would you advise a young couple who are unaware that they may have a genetic condition to get tested, genetic testing before they get pregnant?
Of course. I think and I believe that in a few years, people will sequence whole genome to find whether they carry a mutation. In Israel, we are very close to it because they expanded the screening program, which part of it, only a small part of it is paid by the government. Most of it is paid privately, but still now it diagnosed more than 700 mutations without any indication, just because we know that we carry many mutations and we don't know if we have any relation, family relation with our partner, maybe 1,000 years before, I don't know. And to be on the safe side, it is only a matter of money. So I think we have to check everything we can.
I want to add, I think that knowledge is our power. And I think most of us didn't know that they have this disease. I didn't have any patient in my family, and I was the first one that was diagnosed. But I think that
which is always happen in the recessive disorders. We have
Yes.
no sign.
Yes. And I think that if someone has told me, or to my parents before 40 years ago, that they are carrier of this disease, I think that they will do anything they can to prevent giving a child with disease. And this is our mission. Now we know that we are a carrier or patients in our family. And I think this is our mission to help the world become with less disease. And not better, because I think we are the best, but
Definitely.
and we are precious as the same we are. But if I will have the opportunity to choose, I will do genetic screening, and I encourage each one of you to do this and to ask your families to do that.
I agree.
So, Mira, do you want to bring up the last slide?
I will try to. Maybe I will do it just to return to the beginning. It will be probably the easiest way. Okay, so key takeaways. It is possible, we have to remember, it is possible to avoid the birth of an affected offspring. We should use the knowledge and the experience, and we have to be a part of the modern world and stop the transmission of devastating mutation to the following generations.
And by that, Mira, I want to thank you so much, really, for your time and for your effort. And our mission is to educate the next generations and to maybe leave you without work at the end.
Yes, I agree. Thank you.
Okay. So thank you everyone for participating in this Zoom, and thank you, Mira, again for your time.
Thank you.